I'm Rob Story from the University of Sheffield in the UK. I'd like to welcome you to this session on balancing the safety and efficacy of antiplatelet agents and the role of platelet function testing in that. Got a panel today from a variety of specialties. I'd like to welcome them. So we have Stavros Spiliopoulos from the Department of Interventional Radiology in Patras University Hospital in Greece. Welcome. Antonio Colombo, Director of the Cardiac Catheterization Laboratory in Milan, Italy. Welcome. And Guillaume Taylor, anaesthetist at De Rothschild Hospital in Paris, France. Welcome. And Jeff Dalen, Chief Scientific Officer of Acumetrics in the US. So I'd like to start by talking about the response to antiplatelet drugs and how we might measure the specific effect of the antiplatelet drug. Stavros, what's your sort of take on this theme?
So it's a new thing for interventional radiology, really, and we are only beginning to understand the importance of platelet function testing in our practice. And I think that the most useful thing that you might have in your laboratory is a point-of-care test, a bedside test where you can just take your blood sample, or you or your nurse, and have a result, an immediate result, not waiting for a laboratory analysis. That varies from laboratory to laboratory, and you need an immediate answer whether your patient is covered with your antiplatelet therapy. Because in PAD, we are dealing with patients that are not only are claudicants, but sometimes they suffer, not sometimes, many times they suffer from critical limb ischemia. And you don't want your patient to thrombose and lose a leg, because some people think, well, it's just a leg. No, it's not just a leg. There's a 50% mortality in the first year after major amputation. So it's a major issue in our practice too.
Mm-hmm. So the stakes are high, you know, whichever territory is threatened. Antonio, what's your sort of take about the territory that's threatened in coronary stenting and the specific effect of the drugs?
You know, when you look at the event rate in the published trials, especially with new generation drug-eluting stents, the event rate is sometimes below 1.5%. And you really wonder what is the value if you are dealing with such a low event rate. But when you start going to some subgroups, like patients with acute coronary syndrome, acute myocardial ST elevation MI, complex stenting, even in the context of stable coronary artery disease, the situation is different. So maybe instead of using these tests in everybody, we could sort out the so-called higher risk patients and focalize in those patients. That applies to every field of medicine. By doing that, you decrease the number needed to treat, you focus on a more high-risk population, and you use your resources more effectively. Unfortunately, no trial has specifically, maybe with the inclusion of the acute coronary syndrome, but really no trial has specifically focused some subgroup of patients, diabetics on insulin, patient with chronic renal disease, etc. And you may even include the so-called group of patients who have high risk of bleeding, because the bleeding issue is the other side of the coin of the thrombosis.
And we sort of talk about sort of event rates, low event rates. I mean, elective stenting, very low event rates for most patients. But there's two sides to this, because the patient, when you come to consent them and say there's a 1 in 300 risk of dying as a result of this procedure, they think that's quite a substantial risk, you know, for you know, percutaneous procedure. So, you know, there's this sort of difference between treating populations and treating the individual patient, and how we'd perhaps treat one of our family in terms of these sorts of procedures. So do you think from that sort of emotional point of view that knowing what you've got in terms of a response to antiplatelet drug, is the right thing to do?
My personal opinion is yes, because to take the other approach and give a more potent drug to everybody, first of all, a more potent drug we know sometimes has more side effects and may lower compliance. In addition, a more potent drug may not be a good approach in the patient who is a good responder, because this fact may further increase the bleeding risk. But these are indirect interpretation, because if we go by evidence-based medicine, no specific trial has demonstrated that we can do something. They have demonstrated that people that have poor responsiveness don't do well. Patients that have good responsiveness bleed more. But the link between possibility to correct in a better way these abnormalities is still waiting a proof.
So we've got the ability to measure drug response, but what we need is evidence for how to individualize therapy in order to improve individual patients' risk of the procedure.
But my critique to the person who says, listen, we have quite a large number or reasonable number of randomized trials and none of them succeeded. Every trial so far published or conducted, maybe not to the very end like the trigger PCI, is that there were major limitations. Gravitas used the wrong approach to correct abnormal PRU, took too many patients with low risk. Arctic, again, used the prasugrel not in every patient, but only in 30% of the patients. Trigger PCI, the event rate was very low. So you have to recognize that unless you do the right evaluation, you cannot pronounce the sentence. I think we are giving the sentence too early without the fair trial.
Yeah. And so, Guillaume, how do you perceive this issue of response to antiplatelet drugs in your field of intracranial procedures?
Like Stavros said, when there is a major complication, it can be a catastrophe for the patient. So we place ourselves in the shoes of the patient. When we draw blood to do the testing, it's not to evaluate the risk. You draw blood, doctor, why are you drawing blood? Because I want to know if you have high on treatment reactivity. Okay, what is the result? Well, you have high on treatment reactivity. What you're going to do about it? I'm going to increase the dosage of clopidegrel or change the drug to prasugrel or whatever. And the patient says, are you testing again to know if this is efficient? Well, we believe we should do that. If an intervention is done based on the result of platelet reactivity, we should test again to know if this intervention has modified the result, has turned a patient with high on treatment reactivity to acceptable on treatment reactivity. By doing this, we believe we can lower the risk, and I think Professor Colombo was saying that the trials that have been done until now in the cardiology field have been disappointing in terms of results because their design was not exactly right, and he was talking about the drugs that have been used, different drugs, like some patients on prasugrel, others on GP2B3As, so difficult to interpret in the Arctic study in particular. All these studies have the same drawback, I think. They did not test their patients after the modification of the regimen based on the initial result. So we do not know if this intervention was in fact efficient to cure the high on treatment reactivity that was diagnosed with the test initially.
So we have a bit of a tension here, don't we, between evidence-based medicine and what seems the obvious thing to do. On one front cover of the BMJ, they had an article about sort of parachutes and why haven't we done a randomized trial of jumping out of an aeroplane with and without a parachute? It's obvious. So do you think response to clopidegrel falls into that sort of category, sort of parachute study? Would patients, if you really sort of laid it out to them, tolerate taking part in the study when it seems so obvious to them that they need to be responding to the drug?
I don't think it's that obvious. I think evidence-based medicine can be the answer to the question, but for that we need the trials to be designed in the right way to answer the right question. Do we need a test to evaluate a risk, or do we need a test to guide therapy? And it's not the same problem. We hear about tailored therapy, but up to now I've never seen a proper study that tailors therapy with a goal and has tested patients to evaluate if that goal has been achieved.
Jeff, what's your sort of take on this, sort of assessing the drug to the assessing the response to clopidegrel, and it seems such an obvious thing to do, and do you think we've got the test that allows us to do that?
Well, I think so, and I think that we have to keep in mind the goal of giving the antiplatelet therapy, and that's to see a pharmacodynamic effect of the drug, because that's associated with lower rates of thrombosis, but carries along with it the increased risk of bleeding. And in terms of having evidence for that pharmacodynamic effect, what I mean by that is that it's distinguishable from baseline, so that you're able to distinguish the patient who's taking the drug from one who's not. And I heard an interesting comment about curing high on-treatment platelet reactivity. And that's also the purpose of giving the drug, is to cure high on-treatment platelet reactivity. And in terms of the risk profile of the patients that might benefit most from platelet function testing, it's probably those that would benefit the most from having their high on-treatment reactivity cured. So there you're talking about the patients with diabetes, the patients with ACS. Those are the ones that stand to have the best chance for improved outcomes by taking the drugs. And so you could argue that those are the ones that really should be tested to confirm that you do have the drug effect on board.
So Stavros, what's the evidence for drug response having an impact on outcomes with peripheral vascular disease and perhaps procedures that you might be doing?
Well, the data until today are very limited, and that's a major problem. There's only 1 or 2 studies coming from our group that have demonstrated the clinical significance of high on-treatment platelet reactivity in PAD patients. And of course, there are single-center studies, including 100 patients. They're not large-scale, multi-center randomized trials that could demonstrate the importance of the phenomenon. However, there is a strong correlation between repeat procedures and probably mainly due to restenosis and not thrombosis, unlike the coronary studies. So there is a strong correlation between repeat procedures in our patients and high on-treatment platelet reactivity. And these are only the initial data, and we have to further investigate this phenomenon because it's very, very interesting.
So in the peripheral arterial stenting, do you think, do you perceive there's a relationship between thrombosis and restenosis?
Yes, of course.
How quickly are you seeing patients restenose?
So we had, in our study, we had the first occlusive events after 2 months after the intervention. But the patients did not come to us with acute limb ischemic symptomatology. They came to us with just relapse of the disease. So it's only natural to think that it was not an acute event that happened. It was a restenotic, hyperplastic, aggressive event that rethrombosed. I don't know if you understand. There is a difference there. And so we are talking about the pathways of restenosis that might be related with antiplatelet therapy and high treatment reactivity. We don't know much about that. We already know that PDGF, platelet-derived growth factor, is a factor that stimulates smooth muscle cells migration and proliferation, which is a main pathway for restenosis. And we already know that platelets are involved in the initial inflammatory response to barotrauma with the release of various chemokines. So there is probably a correlation between antiplatelet therapy and restenosis too, not only thrombosis. And that's very interesting because it has to do with the duration of antiplatelet therapy. That's why in peripheral arterial disease we say you have to cover the patient per life. Just give antiplatelet therapy if it's not contraindicated forever. But which antiplatelet therapy? Dual antiplatelet therapy, monotherapy, Plavix, clopidegrel, aspirin? We don't know yet.
Yeah. So we sort of found in some mouse work that P2Y12 plays a critical role in near-intima formation after vascular injury, and but in terms of clinical studies, we're at seems quite an early stage in terms of evidence evolution and understanding what happens in peripheral procedures and how antiplatelet effect may drive some of the potential complications.
And we have to bear in mind that we're not talking only about small vessels that are stented with drug-eluting stents. We are talking about larger vessels, iliac vessels, vessels that have diameter of 9 or 10 millimeters. We're talking about the femopopliteal axis, which is a long, we're talking about long disease, really long disease of 20 centimeters. And then we have the combination of those and poor runoff, which is sometimes stented in order to have a nice straight line down to the foot and save the foot. So we have a combination of devices that are used, balloons, drug-eluting balloons, drug-eluting stents, in a combination of vessels. It's very more complicated than the heart, I think.
Antonio, in the sort of coronary treatment, do you think we've sorted out restenosis pretty well and are fairly comfortable about how quickly stents are likely to endothelialize in terms of how long we continue antiplatelet therapy and the intensity? Or do you think there's still issues there in terms of individualizing treatment and reducing the risk of restenosis without compromising healing?
But I think we have clarified that platelets, unless some new discovery comes out, do not play major role in restenosis. Potent antithrombotic therapy, they did a specific randomized trial with abiximab, ERASE, to try if they could lower late loss with potent antiplatelet therapy, and the trial was negative. The antiplatelet therapy is focused on thrombosis. Unfortunately, the risk of thrombosis is never zero, even after a long time, because some stents don't fully endothelialize. Sometimes you have new plaque underneath the stent. Sometimes the old plaque did not heal. So in some circumstances, very rare, and you don't want to treat every patient for indefinite amount of time when the very late stent thrombosis is the order of 0.5 or even less %. But still, the goal is to find who is the high-risk patient. That's what is missing in order not to have the number needed to treat so high, because unfortunately we know that from the platelet reactivity study there are patients that have good response that have a high risk of bleeding. So if you treat those patients for extended period of time with a potent antiplatelet agent, you expose the patient to a high risk of bleeding. So you really need to take these into account, and to take into account who is the patient who is at risk of late thrombosis. We know, maybe if we believe the data so far published, that we can figure out who is the patient high risk of bleeding. So this is already a progress. We did not know 10 years ago. This information was very minute. Now we know. We still do not know who are the patients who are more prone to late thrombosis. Maybe as a group, the diabetics, especially the diabetics on insulin. As a group, patients who started with myocardial infarction, especially ST elevation MI. So in those patients, you may accept a more aggressive therapy, but mainly to prevent thrombosis, but not to prevent restenosis. And so far we did not discuss the other side of platelet reactivity, which is the risk of bleeding. But I think that should also be explored because we know that if you bleed, paradoxically, you also tend to thrombose. For many reasons, maybe because when you bleed, you stop every therapy, and then you go on the other side of the river. Or maybe because when you bleed, the body, as a natural defense, enhance all prothrombotic milieu in order to stop the bleeding. So, but that's something that is not good no matter where you look at.
And that's clearly something that should be taken into account by physicians when they decide how to react to a bleeding episode, and where possible, not overreact.
Yeah, that's very important. That's very important. Not overreact. Sometimes is you don't. It's no good to have a GI bleed and do nothing. But if you have a stent in the left main and the stent occludes, you die. Period. You still can die from GI bleeding, but if it's recognized, dealt with good supportive therapy, you can carry on.
So for many of our patients, we're sort of walking over a chasm on a plank. But Guillaume, perhaps you might see it that in intracranial procedures, you're walking over a tightrope because the balance between ischemic risk and bleeding risk is that much more severe. Would you say that was a reasonable analogy when you compare the sort of cranial procedures to cardiology and peripheral?
It's probably right. I was talking earlier about a 10% risk of either neurologic deficit or death in stent assisted procedures. So it's a very high risk, even in patients with proper antiplatelet therapy. We always talk about risk-benefit. It seems with antiplatelet therapy, it's risk-risk. The benefit is just in the middle somewhere. And we're not exactly sure, but the therapeutic window is very small, very narrow. I think we should do everything we can to find it, to define it with proper studies, and then, as a physician, to put our patients just in the right spot to protect them from thrombotic events without having a too high a risk of intracranial hemorrhage in our case.
And Jeff, we've got lots of studies, observational studies, and some randomized studies in cardiology, assessing the response to clopidegrel, but not so many in peripheral vascular procedures and intracranial aneurysms, stenting, and other devices. What's your sort of take on that? Can people look at one body of evidence and make assumptions within these other therapeutic areas, or do we need big observational studies in each therapeutic area?
Well, I see two questions within that, and I guess first, in terms of translating, where you correctly point out that the bulk of the evidence is in the cardiology literature, the goals are the same of the therapies, regardless if it's in peripheral artery disease or neurointerventional procedures, and that's to reduce platelet reactivity. That's the purpose of giving the agents. And each of these patients have platelets that are the targets of the therapy. So I think that, generally speaking, the results could be translated across different disciplines. However, it could be that there's even less risk that's desired with certain procedures. For example, neurointerventional procedures. It may not be enough. For example, a PRU result is 97% specific for the drug effect, which means that if you have a result less than that, you can be 97% certain that it's due to the presence of the drug. 97% may not be enough for neurointerventional procedures, so it's possible that the cutoff should be lower. But that's all in interpretation of the test. But regarding clinical trials, what's interesting is it would be great if we had the randomized trial that provided the definite proof that it makes sense to test and it makes sense to get this sort of feedback on the therapy. The three trials that we do have each had limitations, and the Gravitas trial, for example, suffered from a drift of medicine. At the time that Gravitas was designed, prasugrel wasn't available. So it was designed with double-dose clopidegrel, which we found was inferior and not effective in reducing events. The Trigger PCI trial highlighted sort of the change in perception about high on-treatment platelet reactivity, because what they found was about 30% of patients who were identified as having high on-treatment reactivity declined to be randomized into the trial and have a 50% chance of staying on clopidegrel. And as a result, you have a very low-risk population that's enrolled. And the Arctic trial highlighted another challenge with this, because it's not like a pharma trial where you can have a placebo control. You're randomizing information, and you have to rely that physicians participating in the trial will act uniformly on that information. And we saw that there was a lot of reluctance in some cases and with some physicians to increase the potency of antiplatelet therapy. And there was a high percentage of times where the therapy was unchanged. So these are incredibly difficult trials to run, and I think we're getting to a point where there's a lack of equipoise, where there's a general reluctance to keep a patient that's at high risk on clopidegrel knowing that they've got high on-treatment reactivity, just like there's a reluctance to keep a patient who's responding well to clopidegrel and change them to a more potent agent. So it really backs you into very limited options in terms of new trials that would often involve tens of thousands of patients potentially.
Yeah, I think this is a problem that we have seen in interventional cardiology for decades. When you have observational studies that point out some benefit, and then you try to do the clear-cut trial to demonstrate, physicians are not willing to enroll the appropriate patient. We never were able to demonstrate that rotational atherectomy rotablator is useful in a randomized trial. Because if someone needs rotablator, was not inserted in the trial. because he knew that it was needed. So,
listen,
nevertheless, rotational atherectomy is still here.
Same with renal artery stenting.
So when you have the clear cut, but thanks God that physician common sense still has a role.
What do you think is the current clinical utility of platelet function testing then in peripheral vascular procedures?
It's difficult to recommend it because, as I said, there are only small single-center trials, so you cannot just recommend a test in everyday clinical practice based on 2-3 trials. However, it is only logical, as Professor Colombo said, if you have some logical thinking that if you want to give a drug to your patient, you have to know if it works. So we are trying to enroll patients in new investigational protocols regarding the use of platelet function testing in the ambit of peripheral arterial disease, and to see if we can improve antiplatelet therapy and our results by using new, more potent drugs that are not currently indicated for peripheral arterial disease, such as ticagrelor. So we're investigating all this, and maybe a large-scale trial might demonstrate the usefulness of all this testing and modifying personalized antiplatelet therapy in patients with complex CLI disease.
Let me ask you a question. Let's take the total different side of the coin. Patient with acute myocardial infarction, the guidelines now suggest to give ticagrelor, prasugrel, so what's the point to do testing? Should you consider testing in order to evaluate the patient who has a high risk for bleed? If after prasugrel you get a very high platelet inhibition, 95%, 10 PRU, should you be concerned to leave that patient for 6 months on prasugrel?
Yeah, that's correct.
So
yeah, that's
this has never been looked at,
No.
but I think we should also take this issue into account, because we know that that patient may be at a high risk of bleeding.
I think it's the same thing with warfarin. We test the INR, no? If the INR is 7, you have to adjust your therapy.
You know,
I mean,
many
it's
people
only natural.
are not convinced, and
I think the issue in acute coronary syndrome with ticagrelor is the mortality benefit compared to clopidegrel therapy, and the uncertainty about the mechanisms for that, whether it's related to P2Y12 inhibition or off-target effect. And so until we've got a clear idea about that, it's difficult to know what is your target level of platelet inhibition in those patients.
you know, and they did the randomized trial in acute coronary syndrome, the Plato, and if you look at the manuscript, the bleeding in the ticagrelor was not so bad. So the scientists will argue, okay, your rationale is there, but the data don't show that you have a lot of bleeding. But still, if you concentrate on some subgroup of patients who have a high platelet reactivity, I'm sure, I mean, nobody's going to do a trial, but if you give a prasugrel or ticagrelor and you look at all patients who have less than 20 PRU, I'm sure that if you leave those patients on long-term potent antiplatelet, they're going to bleed.
I think, I mean, our experience was that with ticagrelor, the platelet reactivity is very consistently very low. But I think the important point to bear in mind is that Plato, Triton, even Cure excluded patients who are at higher risk of bleeding.
Yeah.
And we
From
get
the
those
beginning.
patients. We get the patients with iron deficiency anemia or perhaps sort of ongoing GI blood loss who yet sort of need coronary stenting, and they fall outside the evidence base for more potent drugs. And for sure, in those patients, we know if they don't have any P2Y12 inhibition and we put a stent in, they're going to be at high risk of stent thrombosis. But if you have a high level of P2Y12 inhibition, then you're going to exacerbate the bleeding. And so potentially for those individuals who are outside the main evidence base, those are ones who, tailoring the drug response makes a lot of sense, and we may not, have a big enough study really to tell us it's the right thing. So I think, that's why, individualization of therapy, is likely to be the solution for quite a number of patients who, who we don't have an evidence base to support.
And even in the Plato trial, now I remember, even if the bleeding event was not so different, and even the major bleeding, if you dissect inside the major bleeding, in the Plato they had more intracranial bleeding.
Yeah,
so certainly there was more. There were more fatal intracranial bleeds with
and we know what the difference between a major GI bleed and an intracranial bleed.
And I guess, Guillaume, that has sort of implications for your area. The fact that we know high levels of P2Y12 inhibition associated with more potent drugs, prasugrel and ticagrelor, predisposed to potentially fatal intracranial bleeds. So that sort of goes along with the sort of therapeutic window concept in intracranial procedures, which is sort of supports the strategy that you've got in your centre to titrate to within a particular therapeutic window.
Exactly, and we are very reluctant to change drugs from clopidegrel, which has its downsides, we all know them, to other more potent drugs that might lower the level of thrombotic events, but also increase intracranial hemorrhage, which have very dire consequences for the patient. We don't see the antiplatelet therapy as a drug problem. We see it as an effect. We are looking for an effect on the platelets. We are able to measure it. So if we can measure it, whether it is given by 2 tablets a day of clopidegrel or 5 milligrams of prasugrel is not important. The aim, the goal, is to get your patient on the right window. And I think to keep on the subject of intracranial hemorrhage, patients with hemorrhagic intracranial stroke who are on antiplatelet therapy, maybe after PCI or for another reason, and come to the emergency room, may benefit from platelet transfusion if they are responders to the treatment, or may not require platelet transfusion if they are not. And there is no trial that has shown the efficacy of platelet transfusion in an emergency setting for patients with intracranial hemorrhage under antiplatelet therapy, because nobody has ever bothered to test if they are responders or not. So if you take all patients under antiplatelet therapy as a bulk group and you transfuse them when they have intracranial hemorrhage, you cannot show that platelet transfusion is efficient. But if we looked which patient is a responder, maybe we could show that platelet transfusion is efficient in these subgroups.
And platelet transfusion, not necessarily a benign process in patients who are critically ill, as I guess some of your patients are, requiring ventilation and potential for sort of lung injury and general systemic inflammation.
And there is a shortage of platelets. They are very, not only expensive in a financial point of view, but they are rare. We cannot give them to every patient. So I think selecting the patients who could better benefit from platelet transfusion should be an option. And testing them, I think, could help us.
And in the intensive care setting, I mean, the intensive care medicine has progressed through measuring as many physiological parameters as is possible and trying to maintain the sort of physiology. So I guess, you know, platelet function falls within that concept.
Yes. It's been shown that when a patient comes to the hospital with intracranial hemorrhage, even if he says he's not on antiplatelet therapy or his family says so because he's in a coma and he can't answer, 30% of patients have been found to be responders to aspirin when tested blindly. So screening patients with life-threatening hemorrhage, I mean, we do INR in those patients to know if they have normal hemostasis. So we should test platelet function for the same objective, to correct hemostasis and to restore normal clotting in these patients with life-threatening hemorrhage.
Okay, well, I think we've had some great discussion there and drawing parallels between the different therapeutic areas. Clearly, there's similarities in some ways with heart, brain, peripheral vascular procedures in terms of the balance between ischemic complications and bleeding complications, and we clearly all have to balance between those risks and in order to try and get the best outcomes for our individual patients. And all of us also in each of those therapeutic areas hoping for more evidence to evolve that will support rational management of antiplatelet therapy. So thank you very much indeed, everyone, for your contributions to this discussion.